Each year, millions of adults in the U.S. are diagnosed with vascular disease. And it's no wonder. With over 60,000 miles of intricate arteries and veins throughout the human body, there are bound to be complications due to blockages, weakening of the blood vessel wall, and other issues impacting the circulatory system. With an aging population and the growing incidence of risk factors such as diabetes, high blood pressure, obesity, smoking, and the disproportionate incidence of vascular disease in our minority populations, the management of vascular health is becoming a key focus among today's healthcare leaders and providers. As with any medical disease or condition, it takes an entire team of dedicated professionals to find new ways to efficiently diagnose and treat patients, as well as to improve their long-term care. In vascular health, the leader of the team is today's vascular surgeon. Only vascular surgeons dedicate their entire training and practice to address the full spectrum of vascular health, as well as provide comprehensive care that includes preventive, medical, surgical, and minimally invasive solutions. Through ongoing education and research, as well as pioneering new techniques, vascular surgeons are on the leading edge of clinical breakthroughs that are transforming vascular health. As part of their comprehensive approach, vascular surgeons partner with other healthcare professionals to provide quality care tailored to each patient. This patient-centered model is vital to help all physicians manage vascular health in at-risk populations and promote healthier lifestyles in the future. Vascular surgeons are involved in every part of the disease process, from making the diagnosis to the management of disease. Vascular surgeons are comprehensive leaders in vascular health. Today's vascular surgeons are creating a new chapter in the vascular health story with improved patient care, better outcomes, collaboration, and leadership. Surgery is only part of our story.
Good evening, everyone, and welcome to another SVS Town Hall, devoted tonight to a discussion about our recently completed first appropriate use criteria, this one devoted to claudication and how you can incorporate this tool into your practices to optimize patient care. Before I introduce our speakers for this evening, let me begin with acknowledging that this will be the last SVS Town Hall that I will be emceeing. But before I ride off into the Town Hall sunset, let me provide a brief recap. These town halls were initiated in the spring of my presidential year when it became apparent that SVS members would be facing significant challenges related to the COVID-19 pandemic. Over the ensuing 4 months, we produced over a dozen town halls on a variety of poignant topics and received resoundingly positive feedback from you, our members. Over time, and after a break for SVS Online, we began using this forum to inform and educate our members about other significant issues, as we are here today this evening with our appropriate use criteria presentation. Sadly, with COVID resurging, we had to update some of the COVID information as well. I hope that you have enjoyed and benefited from the information presented by your fellow SVS members in these town halls. I know that I certainly have, and I've learned a lot myself and enjoyed helping bring this information to you. So it's only fitting that I should wrap up my town hall run showcasing another SVS first, our first appropriate use criteria devoted to claudication. I'm delighted to introduce my co-moderator for this evening, without whose knowledge and expertise these appropriate use criteria would not have been possible, Dr. Karen Wu. Dr. Wu has both MD and PhD degrees and is an associate professor of surgery at UCLA and a distinguished fellow of the SVS. She has noteworthy expertise with the RAND methodology that underpins the development of appropriate use criteria. Also joining us this evening is Dr. Larry Crace, who's a professor of surgery and vice chair of research in the Department of Surgery at the University of Utah School of Medicine. Larry is also a distinguished fellow of the Society for Vascular Surgery. Dr. Jeffrey Syracuse is an associate professor of surgery in the Division of Vascular and Endovascular Surgery at the Boston University School of Medicine. Dr. Syracuse holds both MD and MBA degrees and is a distinguished fellow of the Society for Vascular Surgery. And last but certainly not least is Dr. Jessica Simons, who holds both an MD degree and a master's degree in public health and is an associate professor of surgery at the University of Massachusetts Medical School. This is a spectacular panel to conclude my run of town halls, and I welcome you all and congratulate you on the contributions to the SVS AUC initiative. At this time, I'm going to stop sharing my screen and turn it over to my co-moderator, Dr. Karen Wu, for other presentations. Dr. Wu?
Thanks, Dr. Hodgson. I'm happy to be here tonight, and I'm happy to introduce our first speaker, Dr. Larry Crace, who is the immediate past chair of the SVS Quality Council and oversaw this entire AUC development process and provided the SVS leadership oversight. So I will turn it over to Dr. Crace to tell us about the background behind this project.
Larry, you're muted.
Thank you. The first glitch of the evening. Appreciate your patience. Good evening, everyone. Thank you to all who have signed on. It's welcome. I disclose my role as a member of the AIM Specialty Health Vascular Advisory Panel. Now, when I started learning about clinical practice guidelines and appropriate use criteria, I wondered why there were two different processes and types of documents addressing quality of care. And this is also one of the most common questions I hear when the concept of AUC is introduced. So in this talk, I'll briefly review both types of guidance, compare them, and then make a case for the role of appropriate use criteria, or AUC, alongside clinical practice guidelines. Clinical practice guidelines are defined by the Institute of Medicine, now known as the National Academy of Medicine, as statements that include recommendations intended to optimize patient care that are informed by a systematic review of the evidence and an assessment of the benefits and harms of alternative care options. Over the past few decades, there's been a dramatic proliferation of CPG, and it was noted that some were of varying quality and rigor. Some CPGs seem to advance the particular agenda of the authors or the sponsoring group. So in response to these concerns, standards have been proposed for clinical practice guidelines. And these particular criteria of trustworthiness have been published by the Institute of Medicine. These criteria include a systematic literature review, which may include a meta-analysis if numerous randomized controlled trials are available, a multidisciplinary panel that includes experts and relevant stakeholders who are explicitly transparent in terms of their potential bias or conflict of interest. There should be consideration of affected patient subgroups that may have special values or preferences. There should be an explicit rating of the evidence quality that underpins the guidelines, as well as the strength of any recommendation. And periodic updates are recommended as new evidence becomes available. Every 5 years or so has been often quoted as a benchmark for updating. Now, CPG are based on an explicit framework that assesses the quality of the evidence. The GRADE framework is probably the most well-known, and it's the one that's used by the SVS. The highest quality evidence consists of experimental studies conducted in randomized controlled fashion with strong methods and low risk of bias, or meta-analyses of multiple such trials. Studies with large effect sizes or consistent effect sizes or even dose response gradients are also considered to be particularly high quality. On the other hand, low quality evidence tends to be observational studies with poor controls, high risk of bias, or small effect sizes. When multiple studies are available, they may actually have contradictory outcomes. Moderate quality evidence then consists of studies with a mixture of high or low quality attributes. Now, according to the GRADE framework, assessment of evidence quality is followed by a recommendation for or against a certain procedure or treatment. Strong Grade 1 recommendations are given to measures for which there is a clear difference in benefits and risks, ideally based on high quality Grade A evidence. So a Grade 1A recommendation is unlikely to change or be challenged by new information. On the other hand, weak recommendations, Grade 2, are given when risks and benefits are more closely balanced, only certain patient subgroups may receive the benefit, the evidence quality is low, such as grade moderate or very low, and the recommendation very well may change if new information becomes available. Now, in the presence of a weak recommendation, patient-specific factors may determine the choice of treatment. So in general, clinical practice guidelines deliver one of four kinds of broad recommendations. There can be a strong recommendation for or against a particular treatment or procedure, or there may be relatively weak or conditional recommendations for or against a particular treatment, but these are relatively broad-based statements. The SVS has been in the CPG business for at least 15 years and has adopted the GRADE framework, as I mentioned, to generate its guidelines. The SVS website currently lists 13 active guidelines, and the early documents recommendations were generally based on low quality evidence reflecting the state of the vascular evidence base at that time. I would also point out now that the SVS is updating its guidelines with 8 old guidelines archived that are over 5 years old. The SVS clinical practice guidelines meet all of the criteria for trustworthiness, with the possible exception that patient representatives are not necessarily always included on the expert panels. Now, the recent AAA clinical practice guideline is an example of how SVS CPG have evolved. This document contains 111 distinct recommendations or statements with roughly equal numbers of the statements based on high and low quality evidence. Slightly more than half of these statements were given a strong rating, even though only half of these statements were based on high quality evidence. So while that represents a substantial improvement over the earliest SVS CPG, this document has received criticism for its length, the number of statements, and the number of strong recommendations which were not backed by high quality evidence. This document has also served as the initial template for an attempt to align CPG recommendations with VQI data elements. Well, let's turn our attention now to appropriate use criteria, known as AUC. The rationale for AUC date back to the 1980s, when concerns began to arise regarding over or underutilization of certain procedures or treatments. And these concerns were based in observed wide variations in practice based in geography or patient demographics. There was also uncertainty about how new treatments should be appropriately used. So as the desire to practice so-called evidence-based medicine became widespread, it rapidly became apparent that there wasn't sufficient evidence to make these kinds of decisions for most patients seen in routine everyday practice. The question thus arose, what is an appropriate procedure or treatment, and in what clinical circumstance? Appropriate use criteria are an attempt to answer these particular questions. The SVS has adopted the classic RAND definition of appropriateness, which states that an appropriate procedure is one in which the expected health benefit exceeds the expected negative consequences by a sufficiently wide margin that the procedure is worth doing, exclusive of cost. And the SVS has also adopted the RAND methodology, which is a popular, widely used process to develop AUC. The RAND method will be discussed in greater detail in subsequent presentations. But in general terms, the RAND method is a modified Delphi model of group decision-making. Based on a systematic literature review, an expert writing panel develops clinically relevant scenarios and then presents these scenarios to a separate expert rating panel, which grades the appropriateness of a specific procedure or treatment in different clinical circumstances. The rating panel uses a 9-point scale to rate appropriateness, with 1 being inappropriate to 9 being most appropriate. Let me give you a quick example of how this might work. In general, open repair of a 6-centimeter AAA is appropriate. The SVS clinical practice guidelines would give this decision a grade 1A rating because it is a strong recommendation supported by high quality evidence. You would expect that AUC addressing this scenario would also rate open repair of a 6-centimeter AAA as appropriate, at least for a patient who is a good operative candidate. But suppose your patient has congestive heart failure. Is this decision still just as appropriate? Many clinicians might argue that performing an elective open AAA on a patient with class 3 or class 4 heart failure is actually inappropriate. So AUC allow modification of broad CPG statements based on an individual patient's clinical characteristics. And the appropriateness of a given procedure can be assessed in complicated patients by increasing the number of comorbid conditions and then considering all possible combinations. So let's compare CPG and AUC side by side. Both of them start with a systematic literature review and expert panels. CPG guidelines, however, are consensus statements developed according to a specific framework, and these guidelines tend to be relatively general and broad statements. In appropriate use criteria, consensus is not an explicit goal. Rather, the expert rating panel uses the available evidence to inform assessments of appropriateness in numerous clinically relevant scenarios. Expert opinion is explicitly sought to fill in gaps where specifically relevant evidence is not available. And the final score is then a statistical outcome determined on each panelist's ratings, but not necessarily consensus. Ideally, clinical practice guidelines and appropriate use criteria will not contradict one another, especially when decisions have a deep and strong evidence base. So here's my attempt to place CPG and AUC in perspective and proper relationship. When there is strong and abundant evidence to support a grade 1A clinical practice guideline, either for or against a particular decision, the appropriate use criteria should generally agree with those statements because they are both using the same evidence base. However, in more nuanced clinical scenarios, CPG may not be able to make strong recommendations given the available evidence. Clinical practice guidelines may therefore deliver weak or conditional recommendations. And it's in these circumstances then that AUC explicitly recognize the lack of good evidence and mobilize expert opinion to give guidance. So why engage in the arduous process of developing AUC? Primarily because appropriate use criteria help meet the needs of both practitioners and payers that are not met by clinical practice guidelines. Further, appropriate use criteria developed by experts according to a validated process will serve as strong authoritative statements in the marketplace. There are counter-arguments, however. AUC may be construed as restrictive infringements on physician autonomy. Payers may inappropriately use AUC to deny care in complex situations. And finally, AUC developed using the same process but by different groups may not actually agree. Nonetheless, I think AUC are already here, and I think they will stay. CMS has formally endorsed the process as a means of assessing appropriate use of advanced imaging. And several vascular procedures have already been identified by the Government Accounting Office as supposedly low value, and therefore could be in jeopardy of routine denial. AUC therefore represent a method for defining and preserving their appropriate place in the care of vascular patients. And finally, non-governmental private third-party payers have also expressed enthusiasm for using AUC to make payment decisions. A prominent AUC document already addressing vascular intervention has appeared, and it was endorsed by several vascular societies. This document has caused some consternation within the SVS, which did not co-endorse this document for several reasons. First, only one of the 13 rating panelists was a vascular surgeon, and there was concern that these AUC were much too liberal regarding the use of tibial artery intervention in claudicants. For these reasons, then, the SVS made the decision in 2018 to begin developing our own AUC for vascular procedures and treatments. These AUC will allow us to formally state the SVS position in the public domain and provide a means to advocate against inappropriate overuse. Most important, the AUC should help us deliver better patient care by formalizing a process in which expert opinion is applied to ambiguous but frequently encountered clinical situations. Through this webinar, we are introducing you to the SVS first, nearly complete AUC addressing the management of claudication. Thank you for your attention. I'm going to stop sharing my screen now.
Thank you, Dr. Crace. I'm going to go into a little bit more detail about the RAND appropriateness method now. So the we chose the RAND appropriateness method because it's the only standardized validated technique for determining appropriateness. And as Dr. Crace alluded to, it combines evidence with expert opinion. It's most often used when there is a lack of level 1 evidence. So as Dr. Crace alluded to, if everything had a grade 1A recommendation from the CPG, that would probably not be something that was a good choice to perform an appropriateness method on. So it's often used when we can't perform an RCT in every feasible clinical scenario. So it's been widely used in the past, both in surgery as well as in medicine, and in vascular surgery in particular. It's been applied to carotid endarterectomy as well as AAA. So what we do is it's very clearly prescribed. There's a manual and it's a scientific process. It starts with a systematic literature review and a meta-analysis. And Dr. Syracuse is going to go into more detail about how we executed each one of these things. But we tried to follow the RAND process as close to as prescribed as possible. The writing committee then compiled assumptions and definitions. Importantly, we came to an agreement about how we were going to define appropriateness. So you may see other organizations, other societies defining appropriateness differently. We, as the SVS, agreed to align ourselves with the RAND definition, which Dr. Crace has already mentioned. The writing panel then created scenarios, and the rating panel rates in 2 rounds. So again, when we rate, the panelists rate on a scale of 1 to 9. They were instructed to rate very inappropriate as the risks clearly exceed the benefits by a wide margin, and very appropriate as the benefits clearly exceed the risks by a wide margin. And one thing to take note of here is that the RAND method allows for a gray zone. So this gray zone is the indeterminate zone. So while we don't require consensus, we don't require that people come to a consensus agreement, we allow for this indeterminate gray zone. And the appropriateness is not solely determined by the number. So we calculate the median, the median value of what all the panelists rated, but we also look at disagreement. Disagreement is measured by this thing called the interpercentile range adjusted for symmetry. You don't need to know what this formula is, but it's a mathematical formula that tells you yes or no, was there disagreement? So if there was disagreement, then any median with disagreement falls into indeterminate. If there is a median between 1 and 3, inclusive of 1 and 3, with no disagreement, then it is deemed inappropriate. If the median is 7 to 9 with no disagreement, then it's appropriate. So if we follow the RAND appropriateness method as prescribed, it has a very high reliability and validity. It has a very high retest reliability, which has been shown in the past. If you take the same panelists, you will get the same results. If you get different panelists that are from the same discipline and the same nationality, you will also get the same results. It also has a very high predictive validity, meaning that patients that are treated appropriately will have better outcomes. So this is an example that I really like that was used in coronary revascularization. So what they did was they developed appropriateness criteria for coronary revascularization, but they didn't reveal the appropriateness criteria to the people participating in this study. And they prospectively looked at medical treatment, percutaneous angioplasty, and CABG. And they assigned an appropriateness score to each patient that was managed. But the people who were participating didn't know what the appropriateness criteria were, and the scores were not revealed to them. And they followed these patients for 30 months. They found that 1/3 of those that were scored appropriate for an intervention were actually treated medically. And then this shows you that when patients got medical treatment, when a CABG was deemed appropriate, they had the highest probability of death or non-fatal MI. And then when they got a CABG, when a CABG was appropriate, they had the lowest probability of death or non-fatal MI. So that's what we're hoping to achieve here. We're hoping to achieve a set of criteria that will result in better patient outcomes when they are adhered to. So the RAND process requires that we adhere to a number of things so that we can have valid and reliable results. So they prescribed that it should be led by an experienced investigator. So I've done 2 of these before. I did one on vascular access, and I did the AVF one on venous insufficiency. The investigators should not overlap with the panelist. So there was no overlap between the writing committee and the panelists. The people in round 1 should rate independently. So in round 1, the panelists each rated on their own. They didn't know who each other were, so they couldn't discuss with each other. They each had individual box folders assigned to them so that they had no way of finding out who the others were. And the one thing that we were not able to follow was that it's recommended that round 2 be in person. So given the circumstances, we were unable to do that. The round 2 moderator should be an experienced moderator, and I moderated the previous 2 AUCs that I've participated in. And the round 2 should allow for the panelists to modify any part of the assumptions, the definitions, and the scenarios. And we did this, as Dr. Syracuse will explain a little bit more on Zoom. But because we did all of this, the process actually worked out exactly as prescribed. And the remarkable thing is that in over 2,200 scenarios, there were actually more than this, but we couldn't count the other ones because there was they came to an agreement about the other ones, so we didn't end up counting them. But in the 2,200 scenarios that they re-rated in round 2, that the panelists re-rated, there were only 9 that had disagreement. For 0.4%, which is remarkable. And that just goes to show that the process worked out the way that it was supposed to. So I'm going to try to stop sharing my screen. Sorry, Ryan, I can't find the controls.
Be at the top of your screen.
Okay. So next up, we have Dr. Jeff Syracuse, who is the immediate past chair of the SVS Appropriateness Committee and was a member of this writing committee. Jeff.
Thank you, Dr. Wu. So I'm going to talk about how the SVS actually implemented the process and how we got to here today. So a lot of this started several years ago. Back in 2015, there was a very high-profile New York Times article talking about concerns of overtreatment of lower extremity stents and interventions among Medicare patients. And this was highly visible for the society and for all interventionalists, and really made people take attention. This was highlighted further in Dr. Peter Lawrence's presidential address. and that's that really kind of spurred starting this. So why should the SVS issue appropriate statements? As we said earlier, there's a perceived need. Other societies are doing it, like the ACC one that Dr. Cray showed. Payers are likely to base coverage decisions on appropriate statements at some point. And if we don't do it, someone else will. We probably won't like it, especially if it's driven by people that don't do open surgery. Oftentimes, interventions are going to probably be minimized in the scenarios. The definition of appropriateness, that Dr. Wu said earlier, is the expected health benefit exceeds the expected negative consequences by a sufficiently wide margin that the procedure is worth doing. We met in Chicago at the SVS headquarters in 2018 and really fleshed out a lot of the ideas of how we're going to do the process. Overall, the PR tagline, the short tagline is the right care, right patient, right time, right provider, physician, and right place. Cost is not to be considered in this process. And the other thing discussed was, are we going to do a patient versus a problem focused thing? So are we going to talk about AAA or EVAR, carotid stenosis or carotid stent, or claudication or CLTI, or specifically atherectomy? It was decided to talk about the actual condition rather than any kind of specific intervention. The conditions oftentimes would involve those interventions. There's a lot of discussion as far as what statements should be first. So to take this into account, we saw what the current literature review statement status was with the SVS. We wanted to coordinate with the Clinical Practice Guidelines Committee about what practice guidelines they may be revising or putting out soon. And also, what is the public concern about what's going on out there that might be inappropriate or overused, and what do our members really care about that's being done? Some things we considered were claudication, carotid stenosis, CLTI, and AAA. We ultimately chose to do claudication since this is a perceived need by both the public and our society. The writing panel was assembled here. You can see the people here. Dr. Crace, Dr. Wu, myself, Dr. Osborne, Dr. Simons, Dr. Singh, and Dr. Tan. Overall distribution of the United States, you see we're relatively spread out among the different coasts and different parts of the country. The rating panel was then subsequently assembled once the writing panel started their process. The rating panel was an online application with a statement of interest. It was selection with the Quality Council that Dr. Crace was overseeing, the executive board. We decided to have 15 people total, 11 of which would be SVS members. It was important that there was difference in years of practice, that we all didn't have all people that were more junior or people that were all senior. It was important that we were from different geographic areas. We also really wanted to have people both from academic practice and also people from private community and hybrid practices as well. And we really have almost 50-50 representation here among the SVS members of people that were in academic and people that were in community or private practice. We asked the American College of Cardiology and Society for Interventional Radiology for several recommendations. They gave us recommendations, and we selected 2 members from the American College of Cardiology and 2 members from the Society for Interventional Radiology to round out our 15-person panel. Here you can see the rating panel listed here. These are the SVS members. You can see here a very diverse group and different levels of experience, different locations in the country, and different types of practice as well. These are the American College of Cardiology members here. One of them is interventionalist, one of which is a non-interventionalist. And these are the Society for Interventional Radiology members that were given to us, that we selected. And just to look at the geographic location compared with the writing panel, this is the distribution of the rating panel as well. A lot of this correlates with population centers in the United States and practicing physicians. To start the process, we required a formal literature review. Both they do this for the clinical practice guidelines and also for AUC processes as well. This was done in conjunction with Dr. Murad at the Mayo Clinic, who traditionally has done a lot of these, especially for the SVS clinical practice guidelines. 2 specific questions that we asked were, in patients with claudication who are maximal medical therapy, what are the outcomes of initial treatment with exercise therapy versus invasive interventions? And then secondly, in ambulatory patients with intermittent claudication, what are the outcomes of endovascular versus open revascularization or claudication, and we had various subgroups. You see here we had different subgroups based on things such as age, sex, nicotine use, and diabetes. Different outcomes that we focused on were quality of life, walking distance, freedom from major adverse limb events for our literature review. The inclusion-exclusion criteria includes a study population has to have at least 85% of that characteristic to analyze it, and no case reports or case series. Overall, we found that the evidence was very limited that's published out there to guide this, making this an appropriate topic for the appropriate use criteria to analyze. Since as Dr. Wu said earlier, if it was all strong evidence, then there wouldn't really be much use of this exercise process. We did a secondary literature summary with the writing panel, where it was an adjunct to the formal review. We compiled a literature summary based on different characteristics, and we also provided these reference and reviews to the panelists as well for the rating panel. For the writing panel, we fleshed out relevant variables that we thought were important, and we've also spent a lot of time, as Dr. Simons will go through soon, going through definitions, compiling scenarios with different variables, making assumptions and defining these and reviewing these. And these were also initially, before they went to the rating panel, reviewed by the SVS Appropriateness Committee for recommendations and analysis as well. The applicability was very important, that these should be able to apply to the typical and general patient. You can't account for every scenario. As Dr. Wu showed, we had thousands of scenarios already, and it would be impossible to account for every possible scenario. So we tried to avoid having too many zebras in our scenarios. The first round was an individual rating panel on their own for the rating panel. They reviewed the evidence summary, they reviewed the definitions, and they reviewed all the scenarios and rated them on their own. This is the scale that you saw Dr. Crace and Dr. Wu show earlier. The second round normally is in person, but we did it by Zoom. We spent over 15 hours on Zoom. Dr. Wu was the moderator and led this. This was spread over 2 days, a Friday and a Saturday. All members of the rating panel were on throughout the duration. Writing panelists also observed as well. The initial ratings were reviewed. The initial definitions, assumptions, and scenarios were also reviewed. These were modified. Definitions were modified and scenarios were modified as well in select cases. The moderator really facilitated this discussion. We fleshed out ideas, and everyone really participated. It was really a great collaborative relationship between 3 societies. And at that point, after that, they re-rated the scenarios on their own at that point for the final analysis. And I'm going to stop sharing my screen, and Dr. Simons is going to take over and go through some of the definitions and scenarios.
So Dr. Simons is the inaugural chair of the Quality Improvement Committee, which is newly formed for the SVS, and she was integral to the execution of this project. And she's going to talk about one of the most important parts of this project, which was constructing the assumptions, the definitions, and the scenarios. Dr. Simons.
Thank you very much, Dr. Wu. So as indicated, I'm going to talk a little bit about the construction of the scenarios, as well as the mechanics of how that actually ends up playing out with the RAND process. And my talk could also be retitled Meaningful but Manageable, since essentially that's really the principle behind all of the scenario construction, as has been alluded to a little previously. So as you'll recall, the basic steps of the RAND method are depicted here, and I'm going to talk about this box number 2, the creation of the scenarios. The AUC process essentially requires the raters to all be on the same page with respect to assumptions and definitions used in the scenarios. The writing panel began by considering from a clinical perspective what factors are important for decision-making, then coupling that with what data was available from the literature review. Of course, in the real world, there's countless patient factors that we must consider, but the writing panel had to instead try to identify those factors that will most commonly be at play. In addition, the more factors that are included, the more individual scenarios would then be created and require rating. The number of scenarios is a very real consideration. We want it to be meaningful but manageable. And the more detailed the factors are, the number of required ratings can really explode from there. And while there isn't a simple calculation for how many scenarios result per factor, there are some basic rules. And to illustrate how the math plays out, I will start with a generic example here of how the format is. Let's say the STEM describes a scenario with 3 patient factors that are imperative for decision-making. They're all going to go in the STEM. So they would look as this following format. How appropriate is it to do each of the following therapies, 1 to 3, for a patient with X, Y, and Z conditions? And consider all of those conditions are binary yes, no's. So there could definitely be other modifying factors that we would need to include, and those are imperative, and not imperative, but very useful for decision-making. So those would go in as indications, gender and age, as you see described here. And then this is how the math plays out. 3 binary factors, X, Y, and Z in the STEM means 6 stems. 2 modifying factors, one with 2 levels and the other with 3, equals 5 indications per STEM. 3 therapies to consider for each indication equals 15 hypotheticals to rate per STEM, and that equates to 90 ratings total just for this scenario. We felt our goal firstly was to define the situations in which exercise therapy would not be the appropriate first-line treatment, and also to define the appropriateness of different revascularization strategies in the cases where exercise therapy failed to sufficiently manage the lifestyle limitation. So the questions are as follows. What is the appropriate initial management for claudication? And secondly, after a trial of exercise therapy, what is the appropriate revascularization strategy for claudication? Of note, we did not address the relative appropriateness of one type of endovascular intervention versus another. And while we did address lesion complexity, which I'll get into, we did not address multi-level disease. So as we started to think about the factors that are important, we needed to also just set up some clear ground rules. These are the most basic assumptions about the hypothetical patients that we will describe in all of the scenarios. And the first several bullet points essentially are all intended to ensure that everybody is convinced that this is in fact the proper diagnosis of vasculogenic claudication related to a lesion corresponding to the affected muscle group. Finally, the assumption was added, at the discretion of the clinician, the hypothetical patient has been offered a trial of cilostazol. So with that in mind, we sought to identify the factors that from a clinical perspective must be known in order to judge appropriateness. These factors are highlighted here in bold. While other conditions, of course, will be added in, the very most basic required information must be present in the STEM. In this case, we have anatomic level of disease, nicotine use of an antiplatelet agent, and degree of lifestyle limitation. And the number of potential values we decided to give each of these factors in the STEM then ultimately determines the number of stems we have, because every combination of these factors must be represented. And this is what the math looks like. This means there will be 32 stems. If we make degree of lifestyle limitation have 3 levels, we'll have 48 stems instead. If we also add another factor such as complexity of disease with 2 levels, that would equate to 96 stems. So we really want to keep this, we want to be specific, of course, but we also want the work to stay manageable. These are ultimately the definitions that were agreed upon for the first variable, anatomic location of disease. Aortoiliac referred to disease involving the aorta, common iliac or external iliac arteries, but excluding the internal. Common femoral referring to the common femoral and its bifurcation to include the profunda. Femoral popliteal was disease involving the superficial femoral and popliteal arteries. And infrapopliteal was disease involving the anterior tibial, tibioperoneal trunk, peroneal, and posterior tibial arteries, as well as pedal arteries. We also added a term for complexity of disease, straightforward or complex, so binary, and it essentially fell along the classifications of task, A and B as straightforward, C and D as complex, and heavily calcified lesions also constituting complex disease. It's worth taking a bit of time to go over femoral popliteal as sort of a special scenario in which complexity needed to be built out a bit further. So complexity of disease here was not only task A, straightforward lesions was not only task A or B disease and not heavily calcified, but it also referred to scenarios where one could perform a bypass that is above the knee only and with 2 or more tibial runoff. Conversely, complex disease was a situation that required a bypass to a distal target that is in the below knee pop or proximal pleural vessels with single vessel runoff. Conduit also needed to be incorporated into these scenarios and was defined as a binary single segment greater saphenous vein or non-single segment greater saphenous vein. And when the stems are arranged according to the anatomy, we end up with the following 8 sections: aortoiliac, straightforward, aortoiliac complex, and so forth. So going back to the stem, the next factor we needed to define was nicotine use. We kept this simple as a binary current, yes or no. But the next factor, antiplatelet agent, required some discussion. Is it just an antiplatelet agent we're interested in? Is it also antithrombotics? Is it statin therapy as well? Does it matter whether it's prescribed or actually taken? How do we account for those patients who report an allergy? In what ways do these medications impact our decision-making anyway? Ultimately, we decided that some additional language was needed in the most basic assumptions. This allowed us the ability to then define optimal medical therapy as a binary yes/no and only incorporate it into the scenarios in which it was most relevant. We defined it as follows. Optimal medical therapy included antiplatelet and/or antithrombotic and lipid lowering, and patients could be taking both or not taking both. Not taking both would include patients who are not taking these agents for any reason, either one of them, and to include allergic, intolerant, or medically contraindicated. We added these assumptions to the basic ground rules. The hypothetical patient has been prescribed optimal medical therapy, and the hypothetical patient will continue optimal medical therapy after intervention. And lastly, we discussed how to define lifestyle limitation. Should we use a specific distance in street blocks? Should it be measured on a treadmill? Should it be the patient's report or the clinician's judgment? And we arrived at the following. Disabling refers to disabling in everyday life. While it is reported by the patient, there is also an assumption that a thorough discussion has occurred, and the clinician agrees with the patient regarding the degree of lifestyle limitation. The clinician must have explained in detail the rationale that the limitation must be severe enough to justify the risks associated with treatment, to help guide the patient to reporting the limitation accurately. We came up with the following 3 categories: mild, moderate, and severe, which roughly correlated to Rutherford categories. And as an example, mild would be patients who, for instance, may complain that they can't get around on a trip to Europe, for instance, but can do everyday activities without limitation. Whereas severe at the other end of the spectrum would be those patients who refrain from routine errands that require walking. Both the writing panel and the rating panel also felt strongly that there needed to be some way to incorporate something about a patient's overall clinical picture, something that incorporated frailty, functional status, life expectancy. These are exactly, of course, the black and white characterizations that we struggle with every day clinically. And this was ultimately the decision that was reached. Risk status was divided amongst low, medium, and high. And it was an assessment of physiologic reserve based on severe comorbidities, poor functional, cognitive, or nutritional status, and associated life expectancy. And you see the following details listed out there. There were also circumstances in which we felt that it was important to factor in a history of prior interventions and times when the presence of bilateral disease was important to consider as well. And of course, we needed to define the revascularization types. Open inline surgical revascularization referred to an open surgical bypass that is anatomic, including aortoiliac, aortofemoral, femoral popliteal, and femoral tibial. Open extra anatomic was axillary femoral or femoral femoral bypass. Endovascular revascularizations were isolated endo interventions to include angioplasty, stent, and/or atherectomy. And this was based upon the provider's best available intervention judgment. Lastly, common femoral endarterectomy was open surgical revascularization of the common femoral artery with endarterectomy and patch angioplasty. Obviously, what you see is that not every one of these definitions and treatment options is going to apply to every type of anatomy. With the STEM now altered to include anatomic level of disease, complexity of disease, degree of lifestyle limitation, and nicotine use, we're left with 32 STEMs. These were our additional modifying factors included as indications. Surgical risk, optimal medical therapy, walking distance, nicotine use, laterality, and prior intervention. And for example, not every one of these would apply to every scenario. Laterality, of course, did not apply to any of the aortoiliac scenarios, nor did prior intervention factor into any of the question 1 scenarios about initial treatment for claudication. And the final result was a mind-numbing number of hypothetical patients to consider and ratings to render, greater than 2,200 as we've discussed. But I think ultimately it was meaningful and manageable since there was some striking agreement on a few high levels. And with that, I'll stop screen sharing and turn it over to Dr. Grace.
Thank you, Dr. Simons. I just want to highlight how important this part of the process was, because everybody has to be speaking the same language so that everyone can rate starting from the same place. And kudos to the panelists who spent a good 4 hours on this part of the work. And they really were passionate about it and worked it to the point where everyone was happy and everyone thought that it was useful and meaningful. And I'm just really happy with the way that this part of the process worked out. And I'm grateful to the panelists for doing this work. I am now going to turn it over to Dr. Crace. Before I do that, I'm going to remind you that you can put questions in the Q&A section. So we're going to save all the questions for the end, but we will be answering questions at the end. So make sure you put your questions in the Q&A. And now Dr. Crace is going to give us a brief survey of the results.
Okay, thank you, Karen. I'm going to give you a broad overview of the results, which I think will be a teaser to the final document, but I'm afraid I may disappoint some of the people who are expecting very detailed, granular results, but I'll explain this as we go forward. Recall that the writing panel presented the rating panel with two basic questions. What is the appropriate initial management for claudication? And two, after a trial of exercise therapy, what is the appropriate revascularization strategy for claudication? Now, during round two, the rating panelists, as we've heard, discussed and independently rated more than 2,200 individual scenarios over 2 days, 15 hours. A complete and accurate portrayal of the results will require numerous tables and accompanying narrative describing the deliberations of the rating panel as they considered these various scenarios. This is beyond the scope of today's presentation. However, it's important to note again the remarkable degree of consensus achieved by the rating panel, where less than 0.5% of the scenarios met criteria for disagreement. Now, here is an example of a typical appropriate use criteria results table that will appear in the final document. Proposed treatments are listed in columns across the top, while the scenarios are listed as rows along the left-hand side. The appropriateness rating for a proposed treatment in a given scenario will be shown in the intersecting box. Appropriate treatments will be colored green, inappropriate treatments red, and indeterminate will receive a yellow color. Now, in this table, there is an appropriate treatment for all scenarios in column 1, as well as an inappropriate treatment in all scenarios in column 3. Other treatments may be appropriate or indeterminate in certain circumstances. As you peruse the table, when the color pattern changes, one can usually understand why by referring to how the scenario changed in the row. For instance, treatments in columns 2 and 4 become more appropriate in the scenarios near the bottom of the table. And also note that for some scenarios, there may be more than one appropriate treatment. Now, the reader should expect to find explanations in the accompanying text for major themes that are arising out of the table, or where the appropriateness rating in the table changes systematically. Now, given the large number of scenarios in the Claudication AUC and the inability to present sufficient context, I am not going to present the results of the AUC in this format tonight. Rather, I will give some examples and highlight general themes. For each question, I'll show you an example of a scenario that was rated appropriate by the rating panel and an example of a scenario that was rated inappropriate. And some of the clinical characteristics that tended to sway the ratings in one direction or another will be presented in the yellow box. Many scenarios that involve combinations of characteristics that had opposing influences were thus rated indeterminate. So with regard to question 1, exercise therapy was always rated to be appropriate, regardless of the anatomic level of disease and regardless of the coexisting clinical characteristics. For patients with aortoiliac disease, however, extra anatomic bypass was always rated as inappropriate initial treatment of claudication. When considering the initial management of claudication, increasing severity of lifestyle limitation tended to move more aggressive revascularization options toward an appropriate rating. On the other hand, current nicotine use, while exerting less influence than lifestyle limitation, had the effect of making aggressive revascularization less appropriate. When these two modifiers were simultaneously present, the scenario was often rated as indeterminate. Now, with regard to question 2, concerning appropriate revascularization strategies following exercise therapy, very distinct and clear themes were less apparent than for question 1. However, open and endovascular intervention was generally rated appropriate for patients with severe lifestyle limitation who did not smoke. Open or endovascular intervention for femoral popliteal disease, this is an example, causing only mild lifestyle limitation was generally rated inappropriate. And again, clinical characteristics that tended to influence appropriateness were again, the severity of the lifestyle limitation and current nicotine use with opposite effects. Again, scenarios with a blend of these modifiers were often therefore rated indeterminate. So to recap, between the two questions, the rating panel scored 2,280 distinct clinical scenarios and proposed treatments. Overall, 20% of the proposed treatments in these scenarios were rated appropriate, and about an equal number were rated indeterminate. Most proposed treatments were rated inappropriate when proposed for a given clinical scenario. As anyone who has treated claudication can imagine, the rating panel engaged in robust discussions regarding how numerous clinical characteristics should impact the appropriateness score. And much of this conversation and discussion will be presented in the final document. Despite these discussions, which aired multiple differing opinions, the rating panel's scores reflected remarkable agreement with respect to the final score. And with that, I'll stop sharing my screen.
Thank you, Dr. Crace. Our final talk is going to come again from Dr. Simons as the inaugural chair of the Quality Improvement Committee. She's going to give us some insight into how we might be able to apply these criteria. And I'll remind you that we'll take questions after this talk. So please put your questions in the Q&A.
Thank you very much. Thank you very much, Dr. Wu. So I'll make a couple of comments very briefly on what happens from here into translation to practice. So as has been alluded to, the manuscript next needs to be completed. It's already in draft. It will then be sent to the doc for peer review and evaluation. There will be a public comment period and then a re-review by the doc. It will also be reviewed by the SVS Executive Board. Ultimately, publication in the Journal of Vascular Surgery is anticipated with full SVS endorsement. From there, the big picture is, essentially we really are looking to improve the quality of care for patients with intermittent claudication. And there are many potential opportunities to use this information towards that goal. The SVS Quality Improvement Committee is poised to work with the Appropriateness Committee and the Quality Council on meaningful initiatives. Some ideas include a mobile app to help guide decision-making at the bedside. So this here is featured the Wi-Fi calculator that probably a lot of you have seen before. But basically these calculators often have guides, links to the evidence where it's available. And the SVS has done a great job making these things for a bunch of different calculators of sorts and clinical practice guidelines. Of note, as discussed a little bit before, the AUC for certain diagnostic imaging studies has been mandated by CMS, and the inclusion of that mandate is that for a formal approved clinical decision support mechanism, which is a bit beyond just a mobile app calculator. These are basically typically third-party companies that design solutions that are integrated directly into the EMR. But as a starting point, we could consider an app to help guide treatment. Some other ideas have to do with retrospective analyses and prospective analyses. Perhaps the most obvious retrospective analysis is just a characterization of so-called overuse, procedures performed that match up with an inappropriate indication, and underuse, patients who had an appropriate indication but were not offered a procedure. But other ideas include analysis of outcomes according to whether the intervention was appropriate or not. And both of these concepts can be carried out prospectively, although the potential uses of each are somewhat different. Prospective analyses could be used for provider level feedback. There could be a partnership with VQI to ultimately capture variables such that recurring reports can be generated about appropriate use, analogous to the COPI reports they currently generate. Other partnerships and opportunities could exist to provide feedback to the SVS members, irrespective of their VQI membership status, regarding their compliance with AUC. Other potential directions, well, I would argue that there's lots of options for researching, specifically on the performance of the AUC in comparisons to other AUC documents out there, to help refine and make sure that we have the AUC that really suits our patients' needs. These could also help to guide future implementation strategies. Ultimately, if the goal is to improve care, we will work with all of the membership of SVS to find the best ways to implement these. I do look forward to everyone's feedback, and thank you again to my colleagues on the writing panel and to the multidisciplinary rating panel and to the SVS leadership for supporting this work. Thank you.
Okay, if Blue Sky can bring up the text-to-screen questions. We don't have many coming in yet, but I have one that I would like to ask, and actually several people have touched on this, but Larry, I'll send it off to you first because you made a couple of comments relevant to this. I think our members are going to be very interested in knowing how these appropriate use criteria are going to affect future reimbursements. As you can see, Melissa here has asked us in this question. And what I'm particularly interested in, Larry, is you made a strong point of saying that cost was not considered in this, yet then later on in your talk, you said that the GAO had identified some low value procedures. Well, the value equation is benefit divided by cost. So how does the GAO determine a low value procedure, and how do they convert that into their decision-making process?
Well, thanks, Kim. I'm not sure that the GAO, what they did, whether they used our classic definition to define value. This was basically a paper that was, came up in a web search for appropriate use criteria, and is a government document. Fortunately, I don't think the GAO formally makes funding decisions with regard to payment, but to the extent that this was a signal that CMS ought to look at this, or that third-party payers ought to look at this, I think those three procedures are potentially in jeopardy. And if they're not going to be routinely pre-authorized, then we're going to need some criteria to define when they are appropriate. And it would be better for us to define those criteria than for someone else to define those criteria.
Anyone else want to weigh in on that?
So from the perspective of the manuscript, we're going to be certain to include essentially a, how do you use this information paragraph or paragraphs in the manuscript. So, as Dr. Simons very eloquently explained, we can't cover every single clinical scenario, and we can't cover every single consideration that you take into account when you decide whether a patient is appropriate for a certain procedure. So that will definitely be included in the manuscript. There will always be circumstances where the judgment is left up to the clinician, extenuating circumstances, zebras, those kinds of things. These are meant as sort of broad general recommendations, but they should not be used to bind any one single individual patient decision. Ultimately, the decision-making is left up to the expertise and the judgment of the clinician. That will be at least included in the manuscript. I don't think we can say, how that will be interpreted by payers, But we will be sure to include a statement such as that in the manuscript.
So
I think
one
also
comment
oh,
Go ahead, Jeff.
sorry. I think also the idea of cost not being a factor here is the AUC process is different from what people might do with it afterwards. You know, we have our process we're doing here, and then that's going to generate maybe things down the road. But you know, I think we're trying to just keep the process itself pure and not think too much of those factors.
So just to clarify a little bit around Melissa's question here, what you are paid for doing a particular procedure is probably not going to be impacted at all by the appropriate use criteria. Whether you are paid for doing a procedure, though, I think would be. Is that a fair way of looking at it?
Yeah, I agree. It's not going to calibrate the payment, which is RVU based. It's going to be whether or not the payment is actually approved or denied.
And so do you think, Larry, that in the pre-certification process, our nurses are going to be asked more and more about these other conditions that patients have to see where they fit on the AUC scale?
I think that's possible, but I don't think that's going to happen with CMS yet. CMS is a long way away from implementing AUC for vascular procedures. Their first foray into this was for advanced imaging, and they've since suspended the actual enforcement of even their first use of AUC until 2022. So I think there's going to be quite a bit of time before CMS, which is I think most people's largest payer, before CMS begins to use AUC explicitly in decision making. I think third-party payers, insurance, private insurance, that's a different issue though. But I think you're gonna have to deal with each company individually, which is already a problem.
I also think other societies have been doing a lot of AUCs, especially SIR, Society for Intermittent Radiology, and I don't know of any major policies that have even changed off of them yet.
So, Dr. Grace, there's a related question from Oliver regarding how it will be shared with CMS or the RUC. Do you know if the SVS has plans for that?
None other than just putting it in the public domain. We are not, to my knowledge, involved in any, bilateral or discussions with CMS regarding AUC.
So I can speculate about something that may be a little tangential, but I was the past chair of the Performance Measures Committee, which does a lot of the work with CMS around MACRA and the Quality Payment Program and APMs. And the SVS is still working on trying to construct a vascular surgery APM, and this thing that CMS has come up with called an MVP, MIPS value program, which is kind of like a mini APM. I could potentially see ways of incorporating appropriate use criteria into these sort of things. But ultimately it would depend on whether CMS would approve the construction, however we've decided to construct the APM or the MVP. But I could see that there could be a place in those things for AUC criteria. Anybody, any other comments on that?
Take whichever ones you want of the other questions there, Karen.
Well, let's go with the top one from Dr. Anil Hingorani. Why do you think so many of these scenarios were considered inappropriate? How will this influence the insurance authorization process? Does Dr. Grace want to handle that one?
I think that probably it's a reflection of the particular definitions and comorbidities that were included in the various scenarios. And I got the sense from watching the rating panel in action that basically the stars had to be perfectly aligned for them to be very aggressive with a claudicant patient. Or there had to be extraordinarily compelling indications to do the operation. And when there was a major reason to be skeptical that the operation would be beneficial or something that would increase the risks, I think that tended to sway the ratings towards an inappropriate rating. And then I think I wouldn't make too much out of the fact that the majority of the ratings are inappropriate. I think that's a reflection of the particular mix of comorbidities that were often put into the scenarios. But on the other hand, I think you can also say that that's a reflection of the patients that we see. And this is my personal opinion. I'm not speaking for the SVS now. I think there's probably a lot of over-treatment of claudication using interventions going on. And so that I may have channeled or the rating panel in that way as well.
Well, I think that to expand on that a little bit, I want to applaud the rating panel for being so thoughtful about this. There were certain areas that the rating panel, it was clear that they wanted to make a very strong statement about certain things that they felt were inappropriate. And they modified the scenarios, they modified the definitions and the assumptions in order to address those things. And I think that contributes to the number of scenarios that were deemed inappropriate. But that is kudos to the rating panel for coming together and making these strong statements.
So I may be going out on a limb here, or maybe I'll put some of you guys out on the limb with me here, but I'm aware from conversations I've recently had with Sean Roddy that the increased utilization of certain procedures in certain vascular beds, we're talking specifically atherectomy in the tibials right now for claudication, has triggered reevaluation of that entire PVI code set. And the SVS and the ACC and SIR have now been forced by CMS and the RUC to open up the entire code set and revalue those. Does that speak to the power of these AUC? If we all know ACC published an AUC that rated that tibial angioplasty might be appropriate. I can't remember the exact rating for it, but it clearly was in the possibly appropriate for claudication range. Do you think that maybe that was what drove that extra utilization and the consequences thereof?
I think that a lot of that was probably driven by the increase in costs and payments that they determined they were doing. And I think when you have something go up all of a sudden, it gets a second look.
But I guess my question is, did the AUC that was published give license for more of those procedures to be done?
Well, I think it theoretically gave practitioners cover for doing that. And that bothered the SVS a lot, which is one of the reasons why claudication was selected as the first AUC to complete. I don't have any way of knowing whether or not that was specifically a motivating factor or a reason for the explosion of atherectomy, though.
Olga's chimed in with some clarification, Karen, if you want to address that. I guess there's not a question there.
Yeah, well, I think Olga's question was, if there's so much agreement, why would we need an app or adjustment to the EMR? So there was agreement among the panelists, which is fantastic. We are also very encouraged by that, especially given the fact that we had 2 cardiologists and 2 interventional radiologists. But the reason is because it would help us discern what is appropriate and what is inappropriate. So the panelists came to an agreement on what is appropriate and what is inappropriate, but it's really hard to remember with over 2,200 scenarios. So an app would just give us the ability to plug in the patient characteristics and have it spit out whether or not it's appropriate or inappropriate to do a certain intervention on a patient. I hope that answers the question.
I know that for this AUC, you specifically did not get into the weeds about what kind of endovascular treatment or what kind of surgical treatment. I mean, you did talk about extra anatomic bypass and some of those things, but you didn't get into the issues of DCBs, stents, atherectomy, or whatever. Is that just because it would get far too complex for it? Is there not enough literature on that to make it valid? Or what's behind that? Or is that what's coming up now?
Dr. Simons?
Yes, so we discussed exactly those types of things at the very early stages when we were forming our question. And so essentially, it just would become completely unmanageable to try to have these scenarios encompass every possible endovascular intervention. So the intention was not at all to make it, to diminish the importance of also trying to tease out the best intervention. And it actually didn't have anything to do with the lack of evidence, because that's okay in AUC. But it had, but yes, I agree with you. It would be really nice to see an additional RAND AUC methodology applied to answer that question as a separate question unto itself, so justice could be done to it.
And does the RAND methodology allow for that, Karen? I mean, is that available? That could be done if there was a will. Is there a way?
Absolutely. There's no reason why it couldn't be done. You would just assume that this patient in question has been deemed appropriate for endovascular intervention, and then all the scenarios would have to do with factors that relate to decision making around the type of endovascular intervention you would do. So it could entirely be done, but in the context of what we were doing here as the first time out, we wanted, again, to make it meaningful and useful, but manageable. And it would not have been manageable. I mean, it would have been exponential. It would have been, I don't know, 10,000 scenarios or something ridiculous. So that's how we came to that decision.
So let me ask you another potentially controversial one. Having been through the SVS leadership process, I know that we had been frustrated in the past over writing groups being assembled by other societies where they would ask for one vascular surgery representative or something like that. We didn't think that they were kind of a token voice that was often ignored in those kinds of things. I think one of the things that I certainly encouraged in leadership, and others felt the same way, was that if this is going to be legitimate and viewed as legitimate by all the specialties, that you've got to have reasonable representation. Is 2 from each specialty, each competing specialty, reasonable? Should we be constructing panels differently? Did you see disagreement amongst those? I mean, I don't want to create any conflict here or anything, or betray any confidentialities, but did you notice any disagreements that were significant or worrisome?
You know what? I was remarkably impressed with the degree of collegiality and agreement between the specialties. I see that Bob Patterson has posted a comment. He was one of our panelists, and it was remarkable the amount of agreement between the cardiologist and the interventional radiologist and the vascular surgeons. Like it almost became hard to remember who was what, because nearly everyone was on the same page. And with 4 non-vascular surgeons, the math works out where if there was significant disagreement among those 4, it would have come out in the math, in the way we measure disagreement in the RAND process. And as you saw, there was virtually no disagreement.
And I would just point out that 4 of 15 panelists were not vascular surgeons. That's almost a third of the panel.
You know, we had talked about doing equal representation too at different points, but I think, you know, we also didn't want to be completely outnumbered in the panel either. We need to balance the interests of the SVS and also as far as fairness in the process. And I think it worked out very well.
So it's interesting reflecting on Dr. Patterson's comment there. I was thinking back through my career in vascular surgery, and you know, when I was a vascular fellow, a catheter-associated false aneurysm was an emergency procedure. I mean, you did that in the middle of the night because you were so worried about that. And nowadays, we watch them, we inject them. Sometimes we don't inject them at all, and we just see them back in a couple of weeks. So things change as you learn more about the disease process. And I think that we are much less aggressive about treating claudication than we used to be, probably because we've learned that it doesn't always need to be treated and that it actually does set the patient on the road to further interventions and the need for further treatments. And so it is amazing the things that when I was first in training that were emergencies, you know, just aren't emergencies anymore. Larry, you may be in my age group. You may be able to comment on that too.
I'm with you. I'm amazed at what we don't, I'm amazed at what we can put off now. Still makes me nervous.
So I see Dr. Patterson's comment about vascular surgery going broke doing the right thing. I think that, you know, I think that what we can do with this is that since CMS is moving towards pay for performance, that perhaps if we can show that we've developed these criteria, that they benefit patients, that we can somehow capitalize off of that. I don't know exactly how that's going to happen, but I think, at least I'll just speak for myself, that I would rather go to my grave knowing that I did the right thing. And I think that was reflected in our panelists. I think I was really proud of all of our panelists and how passionate they were about doing the right thing for patients.
You got another question there. How are the benefits of therapy defined? Patency, symptom relief alone? I mean, obviously this is the claudicant population we're restricted to, but be happy for someone to comment on that.
This is more of a preoperative indication thing. We did not go through outcomes as far as for the different scenarios.
So the definition of appropriateness was that the benefit outweighed the risk, essentially. And the panelists, so this will come out a lot, I think, in the manuscript. The panelists did discuss about the SVS criteria, that the expectation is that there's a 2-year period of a good outcome, meaning that the claudication is resolved for 2 years. That was something that they discussed. And to me, that was their primary concern, was that the thing you went there to treat, the symptoms of claudication, remained resolved for at least 2 years. And I think that will come out in more detail in the manuscript. And so tangentially related to that would be things like patency. But I would say that the panelists' main concern was symptom relief and improvement of lifestyle limitation.
So I want to get back for a minute to the issue of cost. When is it appropriate to consider cost in this process? I mean, you set the definition to exclude cost. Could you have included costs? And how would that have played out then? would that have been a change in the way the stems were written, or you would have just allowed your panelists to consider cost in their judgments?
So
I think, sorry, I think cost effectiveness is a whole different area of interest, and that's not really, I mean, until you can consider cost effectiveness, I think you have to consider appropriateness, but then it would be for another body, and preferably not the individual treating clinician, to make a cost effectiveness assessment while dealing with an individual patient.
So I think I screwed up there and removed a question that hadn't been answered, and maybe Blue Sky can get it back for us. One of the ones, I think maybe I deleted two. One of the ones was a question about whether and when more granular results of this can be shared.
When the paper comes out. Well, actually, you'll see it in the public comment period, because the paper will be posted for public comment before final approval after the doc gets its first crack at it.
Okay, so Dr. Legerfeld has a question. Well, that may be a question for the editors of the journal, but how is the work going to alter the review process for articles submitted? I think the point is that supervised exercise therapy was always appropriate in this claudication population, yet we all know that it is rarely done, at least rarely officially done. More commonly, it is what we would call physician-encouraged exercise therapy. More and more I'm hearing, I haven't experienced it myself, but more and more I'm hearing that insurance companies for pre-certification are asking about whether a patient has had a course of supervised exercise therapy, and that may or may not be problematic. I'd be interested in anybody's comments on that.
Within our definition process, we debated whether or not there was evidence to substantiate the use of non-supervised exercise therapy, so-called home-based or technology-based exercise therapy. And we also weighed that with the counter issue, which is that in many cases, even if supervised exercise therapy is recommended, there's no way for a patient to legitimately perform it due to lack of availability of centers or other competing factors, et cetera. And ultimately, there is enough of a body of evidence that we felt it was reasonable to include in our definition of exercise therapy, both home-based exercise as well as supervised exercise therapy. So that's a bit tangential to your question, but that's at least sort of the semantics of our wording.
Okay, we're coming up.
Dr. Hodgson, we already did that somewhat for varicose veins already. We still have to do our 3 months of compression before we intervene in a lot of places with a lot of insurances.
Right, and that's been kind of a long-standing policy for several years at least, although there's really no documentation that the patient actually wears those compression stockings. The only documentation is that you send them away for 3 months with a prescription, and they come back and tell you they're still having symptoms. So one could argue, I think most of the SVS members are aware of the fact that we've been working on an app, a supervised exercise therapy app, and you could argue that this is indeed some level of documentation that the patient is actually going out there and doing the walking. So anyone want to chime in on that? I think Jessica, you mentioned that home-based exercise, there's not a lot of hard data on whether that works or not. Obviously, then, since app-based exercise therapy kind of falls in the same category, we probably don't have a lot of data on that. Are you aware of any?
Yeah, so my own personal opinion, and I was, there was definitely some disagreement within our group. I think home-based exercise therapy works great. And I think that there's good evidence, particularly from Dr. McDermott, suggesting that it does. It just depends on how you measure the so-called effectiveness of it. So basically, it's just training, right? So if you're measuring treadmill walking and you have them walk on a treadmill, you see benefits. But if you have them do home-based exercise therapy, then they report that they can actually walk around home much better if they are appropriately engaging. So there is documentation. I would definitely argue that that substantiates that. And there is also some work that she's initially started working on for technology-based exercise therapy, which holds great promise, but will still have some limitations, of course, as well, based on just limitations of many of our patients to even having smartphones. So I think it's a great concept. I don't know how applicable it will be to, the vast majority of at least my patient practice, but it's a great idea.
Interesting questions come up about the legal system. I assume we're referring to medical malpractice arguments here. Dr. Wu, why don't you take this one?
Well, we know that CPG and other AUCs have been used in malpractice cases. I think that, as I said previously, we will definitely have a paragraph in there that says, that this obviously does not encompass every single patient or every single consideration that you take into account for a patient, and that ultimately the clinician judgment is the most important thing. Unfortunately, we can't control, how it will be used in those instances. But as far as the manuscript goes, we will be sure to include something to that effect. Dr. Crace, do you have any further comments on that?
Well, I agree with everything you said. And I would just say that, CPG and AUC out there, whatever's in the literature will be mobilized to one side or the other's benefit, but that shouldn't stop us from publishing things that we need to take better care of patients. I think that the chips will fall where they may, but for the most part, people who practice appropriately will fare well.
I think lawyers will use anything they can, even case reports and case series. So it doesn't mean we shouldn't do anything.
So Dr. Wu, I'm kind of interested. You were one of the authors, I believe, on the UCLA paper talking about the various interventions, endovascular interventions in the various vascular beds, none of which met the 2-year claudication relief guidelines from the SVS. Have we just been deluding ourselves all these years about what we've been doing?
Well, the data is terrible. So as Dr. Simons and Dr. Syracuse alluded to, we commissioned the Mayo Clinic to do a systematic literature review, and the literature, the results that came back were not even of high enough quality to do the meta-analysis part. So, that gives you an insight into how bad our data is. So I think we are flying a little bit blind with results with regard to evidence-based medicine. And, we have a lot of work to do in that area, but that's also what makes this a really good candidate for the AUC process.
Anybody, I'm sorry, Larry, you got something?
I was going to say there, Kristen is telling us about two questions in the chat that are not showing up on Slido, I guess. One is that they want to see, I think basically the two questions are summarized by saying, we'd like to see more specific results tonight about some things. And I'll tell you that there's been a vigorous debate within the SVS about when to share specific data, and the decision has been made to share it when it can be shared with appropriate context, which is when the AUC document is submitted for public comment.
Dr. Hingorami's asked another question here.
Yep, so with respect to scenarios that are indeterminate, those are what we would consider low-hanging fruit for further investigation. So we know that the data that exists in this field is poor. So some of the things that maybe the first things that we need to focus on with regard to future research are the things that were deemed indeterminate. But yes, if it's deemed indeterminate, then it is up to the clinician. I am not sure how the insurance or payers will manage that, but it will be clear in the manuscript. I mean, it will be clear that ultimately the decision is up to the clinician. And in the case of indeterminate scenarios, the clinician's judgment is all that we really have to go on.
Anybody want to look in their crystal ball and tell us maybe what the next AUC project will be? Or maybe put out a call for suggestions on Connect or something like that? How are you going to make that decision? And who? I don't even know who's going to make that decision.
Well, I think it would be Adam Beck's taking over the Appropriateness Committee, and it'll be in conjunction with the Quality Council and the Executive Board.
Tom Forbes is the new Quality Council Chair. So Tom, Adam, and the EB.
So perhaps if any of our audience has particular interests in future AUCs, they may want to send off some suggestions to those people about what would be of relevance and value to them in their practice. All right, well, it looks like we've been through all the questions. We've gone just a smidge over, not too much. I think this has been a spectacular panel and a great and lively discussion. I certainly appreciate everybody's input. This is a huge amount of work. The idea that you guys spent 15 hours over 2 days, nobody was allowed to leave. It was pretty amazing and a great job, a spectacular contribution to the specialty and the SVS. And I want to thank everybody for their work on that and for their time they've invested in this panel, helping to explain it to our audience as well. So Karen, you got any final comments? Otherwise.
No, I just really want to thank everyone who was involved in this process, particularly the panelists who were all volunteers and spent they rated over 2,000 scenarios twice. So those people deserve a big pat on the back and a big thank you. So next time you see those 15 people, thank them for their service.
All right, very good. Well, thanks everybody, and let you all go now. Have a good rest of your evening, and we'll look forward to seeing you on the next town hall sometime.